Welcome to the lecture for Psych 310, talking about psychotic disorders. In this discussion, we'll focus primarily on schizophrenia and then talk about the other psychotic disorders in comparison. It makes it easier to understand schizophrenia, easier to understand the other disorders if we kind of focus on the one primary diagnosis that's most associated with the psychotic disorders. So, start with the diagnostic criteria from DSM for schizophrenia. 2 or more of the following symptoms for 1 month. And again, kind of like mania with bipolar disorder, it's or less if treated. So if you're having a psychotic break, but they dope you up with medications that make it that take away your delusions or hallucinations, and it's only been 3 weeks, you still meet criteria because the assumption is you would have continued having the symptoms if you hadn't been treated. So 2 or more active phase symptoms, right? I won't talk about active phase, prodromal phase, residual phase later, but these first set of symptoms are all considered active phase symptoms. One of them could be delusions, right? So delusions are just erroneous beliefs that usually involve a misinterpretation of perceptions or experiences. And they can be different. You might classify the type of delusion as persecutory, people are out to get you, referential, things that don't have anything to do with you are because of you. You get that kind of I tripped and fell, and that's why the building collapsed. Somatic delusions, having to do with your body feeling like your hand is not your own, kind of thing. Religious, that you are God or you talk to God, or grandiose, which again you could have grandiose religious ones, but non-religious grandiose delusions would be that you have some special purpose to save the earth, or that you're the king or queen or emperor, whatever it might be. The most common type of delusion, statistically speaking, would be persecutory, that kind of people are out to get you, paranoia type thing, but a persistent belief that people are out to get you. And remember, to be a delusion, not just kind of I kind of feel this way, it really has to do with the intensity of the belief. Like if you feel, I kind of feel sometimes people are watching me, that's not a delusion. A delusion is they are those people over there, so the ones that just walk by, they're following me. They're part of the CIA. They have clever disguises, so watch. Okay, see those people walking there? Same people. They changed outfits. You couldn't even tell, could you? Right? So they have more organized beliefs that are erroneous. They're wrong. And the other important part here is they usually involve a misinterpretation of perception or experience. So it's not just out of the blue, like I think people are watching me. Do you see anybody? No, I've never seen anybody watch me, but I can feel it. Usually there's somebody there, but it's not somebody who's really watching them. Or if they think that God's talking to them through the television. The television may be on. There is audio coming out of the TV, and somebody on TV may say something like, "It's time for you to make a choice." Maybe they're trying to sell something, but they misperceive that as, okay, that's not the TV in a commercial. That's God telling me it's time for me to make a choice. I need to decide if I'm going to be the one to lead my people to freedom. Right. So delusions don't just come out of nowhere. They are usually there's something in the environment, some stimulus, something that they perceive that they're misinterpreting, and then becomes part of this belief system that's really resistant to being challenged, and they very strongly believe it to be true. It's not just I kind of feel this way. It's no, this is definitely this is true, and even evidence to the contrary is disregarded. Usually, people say, okay, here's proof that your belief is wrong. That's usually further confirmation that you're out to get them. See all this evidence you come up with, all fabricated. It's all part of the elaborate cover-up, and they're out to get me. Right? Or if I weren't the King of England, secretly hiding in the United States, you think people would go to all the trouble to make it look like I wasn't? Right? So really persistent beliefs. And again, so that symptom. And then one other symptom, potentially, unless if it's a bizarre delusion, you don't need any other active phase symptoms to meet criteria A for schizophrenia. You need some other criteria, B, C, D, E, and F, but for criterion A for this list, you have to have 2. Well, it's 2 unless you have bizarre delusions. Okay, well, aren't all delusions bizarre? No, not really. If you think people are listening to your phone conversations, it's not all that bizarre as far as delusions go, right? It's possible that the government could be tapping your phone. Like they might be tapping your phone, I don't know. But a bizarre delusion, something that doesn't conform to agreed upon reality, right? So the idea that aliens stole my organs and replaced them with alien organs, and their surgery is done without instruments, and that's why you can't see a scar. Right? Or this belly button here, that's where they took him out and put him back in. That's why I have this hole in my abdomen. Right? That's a bizarre delusion. Aliens taking your organs out. That's bizarre. People following you, not so bizarre. Erotic delusions. The idea that somebody is in love with you. Yeah, that actress on TV, she totally loves me. I'm trying to avoid it, but I guess it's fate. Right? That's not too bizarre. If you say, that rock over there, yeah, that's Katharine Hepburn reincarnated, and she's in love with me. Now we're getting to bizarre, but again, it's a subjective decision whether or not a delusion is bizarre. But if a clinician feels that a set of delusional beliefs are bizarre, then they don't need any other criterion A symptoms to meet criterion A. Okay. But if it's not bizarre, you need something else. So you might have hallucinations, right? And hallucinations, unlike delusions, and delusions, again, there's something in the physical world that's being misinterpreted. Crickets chirping, and you misinterpret that's God sending you Morse code. Hallucinations are whenever you have these perceptual experiences that don't have any connection to the physical world. There's no physical stimuli to be sensed. So you hear crickets chirping, and there are no crickets chirping. Right? And it could be you hear crickets chirping, and it's God talking to you in Morse code, but nobody else hears the crickets. Now it's not a delusion; it's a hallucination. Right? But it may be delusional in nature. I know that can be it's a little confusing. But again, hallucinations don't require any physical stimuli in the world, and they can be involve any of the senses. Auditory, visual, tactile, olfactory. Smelling things that people don't smell. But the most common type of hallucination would be auditory, hearing voices in particular. But if you go, well, geez, in the movies they always see stuff. And why is that? Well, it makes better film, right? It's not that interesting to watch somebody, standing in the corner and looking like they're listening, right? That's not good TV. It's not a good movie. But if you have a person there who they're interacting with, and you can see the person, but other characters can't see it. Oh, that's a hallucination. I get that. But in reality, typically visual hallucinations are fairly rare, and they're more commonly auditory hallucinations. But again, we have this kind of addendum such that, so you don't have delusions, but you have hallucinations. If you have hallucinations, you need one other criterion A symptom, unless the voices provide running commentary, or there are two voices in conversation. So if the voice, you're walking along and the voice is saying, "Why are you doing that? That is so stupid. You're going to screw it up again." And again, it's not, you don't perceive it as your own voice talking to yourself, and I'm just being so self-critical. You perceive it as kind of external to yourself, right? That's what makes it a hallucination. But it's commenting on your behavior. That in and of itself is enough to meet criteria A. Or if there's two voices having a conversation, you're kind of two voices going back and forth arguing. And here's where we get that kind of overlap, the confusion with schizophrenia and dissociative identity disorder, right? Because with dissociative identity disorder, there's these distinct personalities, right? Which at least two of which take control of the person's actions at different points in time, and there may be information shared across identities or across personality states, such that in one personality state you may remember stuff that you learned in another personality state, but there may be some amnesia as well. So this kind of feels like, well, that sounds like what we're talking about here with these two voices having conversation, but it's not. With people with dissociative identity disorder, the two personalities don't talk to each other at the same time. The person might be able to talk about the other personalities. Timmy's really scared about what happened, but Timmy's not in control right now. I'm in control, but they won't have voices talking back and forth in their head. If they do, then it either might not be dissociative identity disorder, it might just be schizophrenia, or it might be potentially both, which would be pretty rare. But if they hear voices and they don't perceive it as part of themselves, commenting on the behavior or having conversations, that is sufficient for criterion A. And it's usually auditory, doesn't always have to be voices, right? Just hearing sounds that other people don't hear sometimes occurs. But usually if you hear a sound and nobody else hears it, what are you going to do? You're going to try to make sense of it, right? So even though people say, oh wow, they're so crazy. This is one of the disorders that people really think of, okay, now that's what crazy is. But there's a lot about the experience of schizophrenia that's very rational, ironically, and not crazy. It makes sense. Like if you have these perceptual experiences where you hear things and people don't hear them, you would come up with some explanation for that, right? So you can see how delusions might follow the experience of hallucinations. Okay, I'm hearing this stuff, other people don't hear it. Maybe there's something special about me. Maybe it's God talking to me, right? So you come up with these explanations for these experiences, potentially. So you might have just one of those, depending on the quality of it. You might have both of those. You might have neither delusions or hallucinations. You could also have disorganized speech, which includes things like derailment. And really, the phenomenon here that we're interested in with schizophrenia is disorganized thought. But we can't see thought. We can't diagnose thought. But we can observe your speech, and it's thought that speech is evidence of thought. So if you have disorganized speech, it's thought to be indicative of disorganized thought. So derailment is kind of when they're talking and they just like you're on a train track and you jump tracks and you shift with no apparent meaning behind the shift. So something's like, hey, I seen you with that puppy. My favorite food is peanut butter, but Wednesdays are always rainy. Right? But those ideas don't go together. Right? So talking about one idea and then derailing, talking about another idea and then derailing and talking about another idea. And that's just one example of disorganized speech. There's other ways. If you just think about if you weren't able to think clearly, you weren't able to put your thoughts in order, which we take for granted, when you spoke, it would come out in that disjointed, disorganized manner. Grossly disorganized or catatonic behavior, including things like catatonic stupor. We can get a good idea of what disorganized behavior looks like, and even catatonic behavior, if you hang out with anybody that does a lot of drugs. Because sometimes if people can drink themselves into a stupor, right? They can drink themselves into a catatonic stupor where they are unresponsive to stimuli and they don't move. Right? That's one type of catatonia, and that can happen with schizophrenia, not because they drank or took a drug, but just because something's going on with their brain, probably, that they're not able to respond to environmental stimuli as you normally would. Not able to move. They might have waxy flexibility, where you can put their arms up in these weird positions and they'll just stay there. And then, grossly disorganized behavior. We take for granted that we're able to organize our behaviors. We're able to, if there's a Coke can sitting in front of you, you can reach out and pick it up and bring it to your lips and drink. That's organized behavior. You're able to coordinate behaviors to match what you want to do. In disorganized behavior, there's impairment in that coordination of behaviors, where you may have these apparently meaningless behaviors where the arms flapping up and down, or they're spinning around. The behavior's no longer organized in a meaningful way. So that might be present. Might also have any of a variety of negative symptoms. And the first four symptoms we talked about in the active phase, we talk about being positive symptoms. And positive or negative, thing about positive being more of something and negative being less. So with delusions, hallucinations, we all have slightly erroneous beliefs. We all might have those instances where we think we hear a name, but we don't hear it. But these are more than the normal experience. Disorganized speech, you may lose your train of thought every once in a while or be confused. But this is more than that. Same thing with, doesn't fit as well with disorganized behavior, but we have some level of sometimes when we're not able to coordinate behaviors to achieve some goal. This is more of that. And the negative symptoms are all about less of psychological phenomena. So things like flat affect, alogia, avolition. Alogia is poverty of speech. So they don't say much. How are you today, Mr. Henry? I'm good. Did you enjoy the turkey sandwich you had for supper? It was good. Not yes, it was lovely. It had mayonnaise and pickles, and I really like those. Or they wouldn't talk that much. They don't use many words. And again, the idea is that there's something going on cognitively that they're not able to communicate in a neurotypical way. And then avolition is the inability to initiate and persist in goal-directed activities. So that's where there's a Coke machine over there, and you've got some money in your hand to get a Coke, and you want a Coke, but you can't get up and go do it. You don't have the will to do things that you want to do. So there's this lack, this diminution of typical psychological functions. And flat affect, I think we talked before, is about the display of emotions. So not displaying any emotions, not smiling, not crying, just very flat and even and kind of Eeyore-like. Okay, so you have 2 of those 5 symptoms. And you could have just one of them if you have bizarre delusions or if you have hallucinations that involve that running commentary or the conversation. Otherwise, you have to have 2 and for a month. And that's kind of the heart of what schizophrenia is. The rest is kind of impairment and other rule-out stuff. But this is really what defines schizophrenia. And depending on what type of symptoms are most prominent, we'll talk about what subtype of schizophrenia you suffer from, which the different subtypes may or may not be meaningful, which we'll talk about in just a little bit. But to finish up the criteria, obviously there's social or occupational dysfunction. So again, if you're having delusions and hallucinations, but it doesn't cause you any dysfunction, you still work. So maybe you're a science fiction writer, and you still crank out 2 novels a year, and you have a nice home on the lake that you live in, maybe by yourself. But you're happy with that. It's not diagnosable. But typically, if you have those symptoms, it's going to cause some dysfunction because the world is made for people that experience the world in an agreed-upon way. And if you hear things that aren't there, that violates some kind of some of our social contracts about what we agree. This is reality, and you're saying you have a different experience of reality than me. That's a problem, right? So you won't fit well in society, which will inevitably lead to dysfunction for a lot of these symptoms. So it's at least a month, and then there's of these active phase symptoms, and then you have continuous disturbance for at least 6 months, with again one month of those 6 being active phase symptoms. So you have at least a month of full-blown delusions and hallucinations or disorganized speech or whatever. 2 of those 5. But then you also, it's not just one, and then you go back to being completely normal and everything's fine, and then you're like, wow, that was really strange, but back to normal, thank goodness, back to work at my job at the insurance agency. Now there's an extended period of time before or after that where some symptoms are present, so there's still some disturbance. But again, to be diagnosed with schizophrenia, it can't be schizoaffective disorder or a mood disorder, which we'll talk about those in just a little bit. It can't be due to a substance or general medical condition, which obviously there are plenty of substances that people voluntarily take to experience some of the symptoms of schizophrenia, right? To get take some acid and get some hallucinations, and have your speech disorganized and get catatonic. I don't know why people do that, but if you are experiencing things because of a substance, it's not schizophrenia. And the idea being that after a certain amount of time after taking the substance, you will no longer have the symptoms, and you only have the symptoms when you take the substance. Then it's not schizophrenia. It's substance-induced psychosis, right? And also not due to a general medical condition. There are certain tumors in the brain that can be associated with hallucinations, and certainly the disorganized speech and disorganized catatonic behavior. Oftentimes when we see those, the first thing they want to do is rule out any kind of brain tumor or other organic, clearly identifiable organic causes in terms of problems going on in the brain. And also not a pervasive developmental disorder. PDD is whenever It's kind of like severe autism and mental retardation together, where somebody has delays in cognitive, social, emotional, and even physical functioning, where they're 18, but they score an IQ test like a 6-year-old, and they don't do much. They can't attend to their personal hygiene without help. So across several developmental areas, some significant delays that don't respond to. It's not a temporary delay where now that they can get caught up. It's something that they've hit this kind of ceiling in some ways, where they're stuck at a certain developmental level that's inappropriate for their age. So sometimes you'll see not so much the delusions and hallucinations, but disorganized speech and catatonic behavior. So it'll kind of look like schizophrenia in some ways. So, but if you have PDD, then it's not schizophrenia, unless you have prominent hallucinations, because those hallucinations really in delusions too, but especially hallucinations are thought to be really characteristic of schizophrenia. But if you just have the other stuff, the disorganized speech and catatonic behavior, and you meet criteria for a pervasive developmental disorder, then you just get that diagnosis, and you don't get the additional diagnosis of schizophrenia. Okay, before I move on to talking about the phases of schizophrenia, I want to go back and just say one more thing about the negative and positive symptoms. Because one thing that's being debated in the literature right now is whether or not these negative symptoms are really, if in fact schizophrenia, as many people believe, is primarily an organically based disease, and not just a response to environmental inputs influenced also by genes, but primarily biological, which is what many people believe, that the positive symptoms are the result of the biological dysfunction of something not working properly in the brain, but that the negative symptoms aren't so much possibly caused by whatever's going on in the brain, but they're a response to the experience of positive symptoms and the feedback they get from their environment. The idea being that if you have delusions and hallucinations and maybe some disorganized behavior, the world's going to treat you in a certain way, and not in a very accepting way. And so you'll learn to rein in your emotions. You won't be very emotional. You used to get really upset when you talk about being persecuted, and you'd see things that scared you and get real emotional. But you got feedback from that, which was negative, so you restrained your emotional experience. You have flattened affect. You don't say much, because when you talk about the things that are going on in your head, people look at you funny, and you aren't able to engage in goal-directed behavior, because you never know when those thoughts are going to come, or people are going to come to take you away. So other people, though, think that the negative symptoms are attributable to the whatever biological cause there might be for schizophrenia as well. But it's a debate, and it's an interesting one. Whether or not it's possible that the negative symptoms might be caused by the positive symptoms. Okay, I mentioned the phases of schizophrenia already. We talked about how you have to have a month of active phase symptoms, but before the active phase, there's a prodromal phase. So a prodromal phase is when you have subthreshold symptoms prior to the active phase. What are subthreshold symptoms? Well, they're when you don't have enough symptoms. So you might just have one. You have one non-bizarre delusion, right? Or you have some negative symptoms, but all you have is negative symptoms. You don't have any of the other ones. That would be subthresholds. Not enough to meet criteria for the active phase. And prodromal is before, right in the time period right before you experience active phase. So you don't know that they're prodromal until you have an active phase. But as we talked about, the diagnosis of schizophrenia involves 1 month of active phase symptoms. So those are the ones we just talked about, those 5. And then after the active phase, most people experience a residual phase. So the course of schizophrenia is kind of this waxing and waning with recurrent active phase symptoms, which sometimes referred to as psychotic episodes. So the symptoms are more intense, and there's more of them at sometimes than others, and it tends to change across time, sometimes in response to the level of stress in their environment, which again makes it feel like it's not entirely biological, because if it's entirely biological, why would it respond to these environmental inputs? Must be some psychological inputs as well. But the residual phase would be subthreshold symptoms following an active phase. So just like prodromal, just in terms of the timing. And the prodromal and residual phases, they may involve attenuated positive or negative symptoms, and or severe negative symptoms. So again, if you just have negative symptoms, even if you have more than one negative symptom, that only counts for one symptom of the active phase. So if all you have are negative symptoms, then it's either prodromal or residual, depending on if you recently had an active phase, met criteria for active phase or not. So sometimes they're severe negative symptoms. Usually that's more likely to occur in the residual phase than in the prodromal phase, which again leads credence to the belief that the negative symptoms are in response to active phase symptoms, in response to people's responses to those active phase symptoms. But they can also be attenuated symptoms that are either positive or negative. Attenuated, which means lessened, not as strong. So they sort of believe these delusional beliefs. I kind of feel like people are watching me, but no, I'm just mistaken. It's not real. That might happen before the delusion gets stronger in an active phase. Or it might be in the residual where, okay, they're no longer believing it as strongly, the active phase is over, and now they're moving into this residual phase. And some positive symptoms are still present, but to a weakened degree. Or it could be no positive and just negative symptoms. Okay, as I said before, there are different subtypes of schizophrenia that are distinguished based on the prominent symptoms. And one of the questions is, are these different forms of the same disorder? Are they just different subtypes, or are they different disorders? And the debate continues. With people feeling very strongly on both sides. Some people saying that, well, schizophrenia is just this kind of spectrum, and depending on where you're at on the spectrum and what kind of experiences you have, you'll have one type or the other. But if we get into the subtypes, we'll talk about catatonic schizophrenia. Is when you experience two or more catatonic symptoms, and the catatonic symptoms may include motoric immobility. That's where you don't move at all. Excessive motor activity. So people that you've heard the term before when we talk about depression, excessive psychomotor agitation. So moving a lot. Same thing might happen with catatonia, which can happen with schizophrenia. Extreme negativism or mutism. And some of these you kind of go, really? Extreme negativism is whenever people refuse to do things. So when you're in the psych ward and the orderly tells you that rec time's over and you have to go back to your room, and you refuse to go, well, that's extreme negativism. You are refusing to comply with commands. Which, I don't know. It's sometimes hard to think about how, is that really a symptom of a disorder, or is that somebody just that's been told to do a lot of things because of other symptoms they're experiencing and not wanting to do it anymore? Hard to say. And then mutism, obviously not speaking. You might also experience echolalia or echopraxia, which is the repetition of something. Echolalia is the repetition of words. So if the doctor comes in and says, how are you doing today? And the patient says, doing today. So not trying to mock, not trying to make fun of, but kind of this meaningless repetition of words. And then echopraxia, the meaningless repetition of movements of others. So doctor comes in and waves, and the patient starts waving, and keeps waving longer than would be appropriate, and isn't clearly waving to anybody, but is just mimicking this motor behavior that they saw. So if those symptoms are kind of primary, it might be catatonic schizophrenia. Disorganized schizophrenia is when there's prominent disorganized speech, behavior, and flat or inappropriate affect. We've already talked about flat affect. Inappropriate affect would be laughing at sad things, crying at funny things. So when your emotional display doesn't match the feeling that you should be feeling. But then the other criteria is you don't meet criteria for catatonic. So if you have prominent disorganized speech, but you also have two or more catatonic symptoms, which one do you get diagnosed with? Well, catatonic, because you meet criteria for it, and you can't have both. Catatonic trumps disorganized, right? Because disorganized is, well, disorganized speech, but not 2 or more catatonic symptoms. So these kind of there's a hierarchy here. So below that would be paranoid, where the primary feature is preoccupation with delusions or auditory hallucinations. But there's not prominent disorganized symptoms. And really, somebody who has paranoid schizophrenia, somebody who has disorganized schizophrenia are fairly different. And there may be paranoia in both, but somebody who has disorganized schizophrenia, their delusions aren't well organized, right? So it's not the CIA is out to get me, and they've bugged my phone and they've bugged my computer. They even bugged some of my food. And I saw a man yesterday walking with a suitcase in front of me, and I think there was a camera in the suitcase that was filming me. That's a fairly organized delusion. Somebody who has disorganized schizophrenia might think people are watching me. Who's watching? I don't know. They're watching, and that may be as far as they get with their delusion. So and the thing being that they can't organize their thoughts enough to have a well-organized delusion. So it does seem qualitatively different. And then undifferentiated, which is a great category for, well, if you don't meet criteria for other types, which a lot of people diagnosed with undifferentiated schizophrenia. If you don't fit neatly into one category, here's kind of a wastebasket category, which I would not because people are trash, but because you don't fit here, there, everything else goes here. Anything we can't figure out or doesn't fit neatly into one of the other types goes in this undifferentiated category. And then the residual schizophrenia, which is interesting because it kind of implies that you'll never not have schizophrenia, because you have residual schizophrenia once you have you no longer meet criteria A, but you have some negative symptoms or attenuated positive symptoms. So as long as you still have some flattened affect, some kind of social withdrawal, or a little bit maybe of disorganized speech. Every once in a while you speak, gets off track. You don't not have schizophrenia, even if you never have another hallucination or delusion. You have residual schizophrenia. Okay, so we've got a hopefully a fairly good idea of what schizophrenia is, right? And it's a lot of things. There's substantial variability in these key symptoms, right? Delusions and hallucinations are two different things. They can co-occur, but they're different. And then disorganized speech is even different from that, and disorganized behavior, well, that's a whole other creature. And then we have these negative symptoms. And of these 5 symptoms, you still have to have 2. So there are several different combinations of these 2 symptom pairings that you could have and be diagnosed with the same diagnosis of schizophrenia. So people with schizophrenia can be very different from one another, which is probably one of the reasons it continues to be a pretty mysterious disorder. But it is seen as some sort of constellation of these 5 primary symptoms, those active phase symptoms. And it can be distinguished from other disorders. And the ones that we would talk about first, not a real important thing. Like, oh, you need, be sure to know the difference between this and this, but just kind of, okay, here's some stuff that's in the DSM. And I say that because the difference between schizophrenia and these other disorders are really about time, right? So schizophreniform disorder is when you meet criteria A of schizophrenia, so you have 2 or more active phase symptoms for a month, or less if treated. So same thing there. So it has to be at least a month, right? But now the whole disturbance is less than 6 months, right? And then there's no requirement for impaired functioning, right? In schizophrenia, you have to have dysfunction in social or occupational functioning, right? For schizophreniform, you don't. So it's thought to be kind of a lesser form of schizophrenia. So you have kind of this psychotic experience. You have these active phase symptoms, hallucinations, delusions, or disorganized behavior, speech, whatever. But then you get better, right? And you don't have any symptoms after 2 months, 3 months, 4 months, whatever. But for a full 6-month period, you don't have prominent symptoms. and maybe it doesn't cause problems, major impairment in your life. One of the reasons this isn't all that significant as a diagnosis in some ways is that about 2/3 of people who diagnose with this go on to get a different diagnosis, either schizophrenia or schizoaffective disorder or delusional disorder or some other longer-term chronic disorder. So for many people, they think that schizophreniform disorder is just well, there hasn't been enough time lapsed yet. You'll see them probably have a 6-month period of having symptoms or have some other symptoms that kind of clarify exactly what the problem is. And most people don't have these brief psychotic experiences that don't go on to manifest some other as some other problem. That being said, it's important to still have this diagnosis in the DSM, because otherwise, when somebody has their first psychotic break and they have active phase symptoms, and maybe they get hospitalized, and they've had symptoms for a month, you can't diagnose with schizophrenia yet, right? So, but they need a diagnosis to communicate among professionals, to communicate to the client, and for reimbursement purposes for insurance. So you have to give them some label, and if you don't want to wait another 5 months to give them a label, well, you can give them this schizophreniform disorder if they've had at least a month of those active phase symptoms. So it's kind of like this stopgap. Okay, well, we think you're probably going to have this chronic problem. We're not going to call it schizophrenia yet because it might not be. You haven't had symptoms long enough. It might be something else. But here's kind of a meanwhile diagnosis. Until we can be sure what's going on with you, we're going to call it schizophreniform disorder. And then the even shorter meanwhile diagnosis would be brief psychotic disorder. So this is when you meet criteria for criterion A for schizophrenia, those active phase, 2 or more active phase symptoms, but for at least a day, but less than a month. So this is that very kind of acute. Somebody comes in and for the past week, past 3 days, whatever, they've been having these hallucinations, and it's really scaring the crap out of them, and it's maybe scaring their family, and they don't know what to do. Again, they need a diagnosis to often to get treated. Well, what's wrong with them? We don't know. Is this? Are they high? Is it? Do they have a brain tumor? If it's not any of those things, there's no identifiable cause in terms of a substance or medical condition. It's some mental disorder. Well, we can't be schizophrenia yet, or even schizophreniform, because we don't know. But your meanwhile diagnosis is brief psychotic disorder. And kind of like schizophreniform, it's pretty rare not to go on to get some other diagnosis. Not necessarily schizophrenia or even schizophreniform. Sometimes people with initially diagnosed with brief psychotic disorder might later find out that they have a bipolar disorder, right? So they might have psychotic symptoms in the course of their mania, or to a lesser degree their depression, but it's their first manic episodes. They've never had depression before. They've never had mania before, so they can't be diagnosed with bipolar yet, because we're still figuring this out. But when they first come in and they're having these hallucinations and delusions, most likely can get diagnosed with something, and that something is brief psychotic disorder, which again, usually indicative of some other chronic problem. It's rare to have the experience of kind of a full-blown delusion and not go on to have some other problem. Just not necessarily schizophrenia. These other ones are a little different because they are actually not just meanwhile disorders, they're actually different phenomenon. One, schizoaffective disorder, which is, as kind of the name implies, kind of this combination disorder of schizophrenic symptoms and affective or mood symptoms. So you have 1 month of mood episode concurrent with schizophrenia's criterion A symptoms. So either depressed while having hallucinations and delusions, right, or disorganized speech, behavior, whatever, or manic while having that stuff for a month, which is a pretty good while, and 2 weeks in the same disturbance, not just like one time in your life and then everything was fine later, but while things still weren't going well during this period of the disturbance where you're having some symptoms, mood, psychotic symptoms, you had 2 weeks with delusions or hallucinations without mood symptoms. Right? So you have the mood and the kind of psychotic stuff at the same time for a month, and then you have the psychotic stuff by itself without any mood symptoms. So your depression lifts, but your hallucinations and delusions don't go away for at least 2 weeks. right? Or you had the hallucinations, delusions first for at least 2 weeks before you got depressed. And then the mood symptoms are present for a substantial portion of the total illness duration, which is very subjective. And clinicians have to just decide, okay, how long have you been having problems? And then try to figure out, okay, have you been having these hallucinations and delusions, and you've had them at the same time, these mood symptoms, you've had these psychotic symptoms by themselves. Over all this time, have you been having, the depressed mood and or mania on and off most of the time, for a big chunk of time? Or does it seem that you have this kind of history of psychosis, and then now you're experiencing depression, which is thought to be, okay, you're experiencing depression now because of your psychotic experiences. The psychosis has caused disruption in your occupational functioning, your social functioning, maybe it's impaired relationships, and there's other things that have put you at risk for depression, and so you have schizophrenia and depression. Right? Or is it that throughout this whole time, it's not just you're depressed now because of the problems of being created in your life by this other disorder, but for the whole duration, you've had mood symptoms and psychotic symptoms. Then it's sort of this combination, this blended disorder of schizoaffective disorder. Right? Which, again, you have to have at least 2 weeks with the psychotic stuff without any mood symptoms, which is what distinguishes it from mood disorder with psychotic features. Right? This is where you have psychotic symptoms exclusively in the course of the mood episodes. And this can happen with depression or bipolar disorder. So major depressive disorder with psychotic features, bipolar disorder with psychotic features. And this is whenever you have the mood episode and psychosis at the same time, but you never have the psychotic features, the symptoms, when you're not either depressed or manic. Right? So the thinking is, okay, well, it only occurs in the course of a mood disorder. It's just a mood disorder with these psychotic features. It's not two disorders together. Because when you're not depressed, you never have hallucinations or delusions. Okay? And then the last one we need to kind of distinguish is delusional disorder. So this is whenever the primary feature of the disorder are delusions. You don't have hallucinations generally. So you have non-bizarre delusions for a month. If you had bizarre delusions, what would you meet criteria for? If you had no other criteria, no hallucinations, no disorganized speech, no disorganized behavior, all you had was a bizarre delusion, well, you meet criteria A for schizophrenia. So if you also had impairment in functioning, and weren't schizoaffective, wasn't caused by drug, then that's schizophrenia. But if you have a non-bizarre delusion for a month, then it might be delusion disorder. But a non-bizarre delusion plus any one other symptom of criterion A for schizophrenia will meet criteria for schizophrenia, so that would be schizophrenia. So it's also, you don't meet any criterion A of schizophrenia other than the non-bizarre delusion. So all you have is this non-bizarre delusion. So somebody that's delusional, but their speech is well organized, they think straight, kind of clearly, in a delusional sense. They think that people are out to get them, but they can talk very clearly about the people that are out to get them, and they don't hear things that aren't there. They don't experience any kind of catatony or anything. They don't have any flattened affect. The primary thing is just they have this belief that is erroneous and intensely held despite evidence to the contrary. Then that would be delusional disorder. Okay. Now we've talked about the criterion of schizophrenia, and then comparing it to these other psychotic disorders, and then also thrown in there were mood disorders, which aren't psychotic disorders but can have psychotic features. Now let's talk a little about etiology. What causes psychotic disorders, and in particular schizophrenia? Like everything else, a variety of things. Evidence for biological factors. Obviously, we know genetics and everything plays a large role. If we look at concordance rates, if somebody has schizophrenia, what's the likelihood that their identical twin would also have it, that their fraternal twin would also have it, that their children would have it, that their siblings, that their parents, on and on. So obviously we see And the color coding is based on degree of relatedness. So the red bar, identical twins, have 100% genetic relatedness. All the blue are 50% related on average. And we see that identical twins have the highest concordance rate, which is evidence of a genetic influence, because they're the most genetically related. But we also see that the graph isn't that simple, right? All the blue bars aren't the same. Even though those people have the same degree of genetic relatedness, you're more likely to have concordance if we're talking about two people born at the same time, even if they aren't genetically identical, right? Fraternal twins. But if we compare fraternal twins to non-twin siblings, fraternal twins, the concordance rate is twice as high. So you're twice as likely to have schizophrenia if your fraternal twin has it than if you have a non-twin sibling who has it. Right? But you have the same degree of genetic relatedness. So genetics can explain everything here. But you also can't ignore the fact that identical twins have a much higher concordance rate than any other group. So genetics play some role. We know that from twin studies, family studies, adoption studies, linkage studies, which is where linkage studies are ones where they find areas of chromosome that seem to be associated with increased risk, right? So they'll map out the genome of people. It's okay. In this family of people who have schizophrenia, they all have this type of gene. And this other group, they don't have that gene, they don't have schizophrenia. And so they sometimes find things like that. But and there's kind of this long history in schizophrenia of research coming out saying we found the gene for schizophrenia from this linkage study. Okay, everybody in this family that has schizophrenia has this gene, and other people don't. But pretty soon after that study is published, more people get their genes mapped, and they find, okay, well, these people have that gene, and they don't have schizophrenia. Or these people have schizophrenia, and they don't have that gene. So usually these findings aren't corroborated. They aren't supported when they announce these single gene findings. So whatever the genetic influence is, it's probably multiple genes involved. And beyond that, it's also the genetic predisposition is probably not for schizophrenia per se. It seems to be more predisposition toward kind of schizophrenic experiences, about being somewhere on the spectrum of schizophrenic behaviors and thoughts. If we think about, remember those personality disorders, schizotypal, schizoid, paranoid, being on the spectrum, you know, somebody who has schizophrenia, if we look at their family tree on down the line, not everybody will have schizophrenia, but a fair number of them will. But also a fair number of them will have schizotypal, schizoid, and paranoid personality disorder, and maybe even schizoaffective disorder or delusional disorder, of other kind of related disorders that are related to those experiences of these kind of odd perceptual experiences, these differences in having problems with thinking clearly. That's what seems to be passed on genetically, and not some sort of pathogen for a particular disorder, but for this kind of spectrum of experiences, which depending on which experiences you have, you're going to be put in one box or the other in terms of these diagnostic labels. In terms of unshared environments, there's also a recognition that the people in the same family may have different environmental experiences. This is used to explain why monozygotic twins aren't 100% concordant. And that some of these unshared environmental influences are probably related to, or can explain why genes don't tell the whole story. But beyond genetics, there's other kind of theories about schizophrenia in terms of pregnancy and birth complications. Obviously, you can't do experiments with this. You can't cause complications with people's pregnancies or with the birth procedures and see what happens. If you did, that would be a very scientific, empirical way of determining if we could manipulate the risk of schizophrenia. Right? But you can't do that. All you can do is look at, okay, of people who have these complications, how many have schizophrenia? Right? And when we look at it that way, people that have pregnancy or birth complications, we don't find there aren't enough people with schizophrenia, and there are a lot of people with pregnancy and birth complications. We don't find a pattern when we look at it from that angle. But if we look from the other side, we say, okay, well, people that have that meet criteria for schizophrenia, that are diagnosed with schizophrenia or a related disorder, they have a greater history of birth complications than other people. So again, the majority of birth complications don't result in schizophrenia. Right? There's a lot of outcomes associated with birth complications and pregnancy complications. But if we compare, okay, this group of people that have schizophrenia, these people that don't, you might see 80% of people that have schizophrenia, probably not that high, but some percentage of people with schizophrenia that had birth complications, and only 10% of people of this other group that doesn't have schizophrenia that had birth complications. So there's something there that may play a role. But it could be that something else explains this. It could be that maternal nutrition is involved, and maybe again, if this child is born and develops schizophrenia, if there's a genetic influence, then maybe the mom has schizophrenia or some sort of schizophrenic spectrum disorder, and may not have sought appropriate prenatal care because of paranoia regarding doctors or who knows what. Also, we know that schizophrenia is correlated with poverty. And poverty is correlated with maternal and birth complications, again, because of less access to reliable prenatal care. So we don't know what this means, but we know there are these associations. Similarly, some people have advanced the hypothesis about maybe there's some sort of viral infection, and usually viral infection during pregnancy. That's involved with schizophrenia, that the developing fetus at a kind of critical point in brain development is exposed to a virus, maybe the flu virus, or either in pregnancy or shortly after being born. And this is based on, again, the fact that people with schizophrenia are more likely to have been born in winter months than in other months. But just like with the other thing, people born in winter months aren't necessarily at a greater risk for being diagnosed with schizophrenia. But people diagnosed with schizophrenia are more likely to have been born in the winter months. So could that be related to something with viral infections or compromised immune system early in life? Maybe. We don't know. Neuropathology, kind of things not structured the right way in the brain. One fairly consistent finding is in people with schizophrenia is that there's a tendency for decreased brain tissue and enlarged ventricles. And ventricles are spaces in the brain, right? Fluid-filled spaces between the brain, between things. So if certain cells die or aren't as well developed, then that creates more space, so you get bigger ventricles. Unfortunately, some of the studies that have documented these kind of differences in ventricle size between people with schizophrenia and those without are looking at people with schizophrenia that they're looking at have been on these drugs to treat the schizophrenia for a long time, and one of the things that the drugs do is cause brain damage and can cause enlarged ventricles. So it's not, in some of the evidence, it's like, well, is that difference due to the schizophrenia, or is it due to the drug? Other studies have looked at people before treatment, sometimes finding the difference, sometimes not. And some people argue that if there's a difference in brain structure, again, unless you find it before they show symptoms, you don't know if the difference in brain structure is causing the symptoms, or if the symptoms are somehow influencing the brain structure. Either way, the brain structure is probably involved. Other findings, sometimes they'll find the smaller structures in the limbic area of the temporal lobe, especially with people that have disorganized speech. And generally, the level of neurological dysfunction, so the degree to which your brain isn't working typically, is associated with severity. Which, really? That makes sense. But if we do these kind of brain scans, and certain areas of your brain aren't lighting up as much as typical patients, which they don't really have a good idea yet of what typical patients are, but based on their clinical experience, they found that that's associated with the level of severity. So people that have more severe schizophrenia, especially kind of the catatonia and the disorganized speech, have more neurological dysfunction. But again, whatever finding we talk about schizophrenia, we'll always find some people with schizophrenia that don't show a particular brain difference, and then we'll find some people that have that brain difference that's been linked to schizophrenia that don't have schizophrenia at all. So the conclusion that's been drawn from this is that schizophrenia is associated with a diffuse pattern of neuropathology, which is basically a way of saying there's something going on in the brain, but it's different things, and we don't know what it is. And it's probably in multiple areas of the brain and not just one area. And that's one reason we can't find any kind of consistent neurological difference. In terms of neurochemistry, the brain communicating, a couple things. One, the classic dopamine hypothesis, which evidence for the role of dopamine in schizophrenia comes largely from the effects of dopamine agonists, right? Drugs that increase dopamine activity. So things like amphetamines. If you take high levels of amphetamines, you'll have symptoms that look like schizophrenia, hallucinations, delusions, even paranoia. And also, we found unintentionally, we give people L-Dopa if they have Parkinson's, which isn't Spanish for drugs, but it's a dopamine precursor. Because you can't give people dopamine into their brain, but you can give them L-Dopa, and the brain uses it to make dopamine. And if you give somebody with Parkinson's too much dopamine, because they don't have enough, their dopamine cells are dying. But you give them too much L-Dopa, and they'll start hallucinating. Well, then it seems like these positive symptoms of schizophrenia may be associated with dopamine activity, right? And we also know that the effects of some of the neuroleptics, which are the drugs used to treat positive symptoms of schizophrenia, they are often dopamine antagonists. They block the transmission of dopamine or limit the effects of dopamine, usually at a particular receptor site. So that's the evidence kind of for the dopamine hypothesis. Dopamine plays a role. But these neuroleptics that are dopamine antagonists don't work for everyone. So for some people, we'll decrease your dopaminergic functioning, and we do that effectively. We can kind of measure, okay, yeah, your dopamine is definitely being affected because you're having these other motor symptoms, but we don't affect your hallucinations, right? So clearly, for those people at least, it's not just dopamine. Also, the delay in symptom change following administration of the drug doesn't seem to correspond to the way they think the brain is supposed to work. That you should see change in symptoms more quickly than what you actually see. The drugs, the neuroleptics, don't have much impact typically on the negative symptoms. So, again, that kind of leaves more credence to the idea we had before about the negative symptoms aren't part of the biological dysfunction, but they're just a response to the positive symptoms, maybe. Okay, so the dopamine hypothesis isn't dead, but it's probably more complicated than just that. And so, like most things, there's probably other neurotransmitters involved. And we know that other neurotransmitters interact with and intersect dopamine pathways. Right? There's not a purely dopaminergic pathway where, okay, all these cells communicate and they use dopamine to do it, and they act and they communicate completely independent of any other cells in the brain. No, there's all these other cells that use glutamate and serotonin and GABA that cross the dopamine pathways and interact, and will make it more likely or less likely that dopamine pathway will be fully activated. Right? And we know that these other neurotransmitters are involved largely because drugs that affect these neurotransmitters sometimes work for patients who don't respond to those typical antipsychotics that are dopamine antagonists. So, like most things in psychiatry, there's some stuff going on with neurotransmitters. We think dopamine is a prime suspect, but it's probably not the only thing. And we know from either increasing or decreasing the activity of certain neurotransmitters, that can have an impact on your symptoms, at least the positive symptoms, primarily. So there's some biological stuff going on, obviously. There also appear to be some social factors that influence the experience, the expression of schizophrenia. One that's often talked about is social class, SES, right? And there's really two reasons for this. And we see schizophrenia associated with people in lower SES. And there's two possible explanations for this, at least two explanations for this phenomenon, for this correlation, both of which might be true. They're not mutually exclusive. One is the social causation hypothesis, and that's that the vulnerability for schizophrenia might be evenly distributed across all classes, so that there is it's not a poor disease, but everybody is vulnerable. But because of kind of a diathesis stress model, only people that experience certain stressors will develop the disorder, and that stressors are correlated, are associated with lower social status, right? If you have low SES, you're more likely to live in a neighborhood that has a higher crime rate, less access to medical care, and fewer educational opportunities. Right? And all those things contribute to stresses in life that might make it more likely that any vulnerability to schizophrenia would be exhibited. Right? So that's the idea that social class and things associated with it are causing the schizophrenia. And then the social selection hypothesis is kind of the downward drift hypothesis, the idea that over time, so at one point in time, maybe everybody, schizophrenia is equally likely to happen to everyone. We're in an agrarian society, right? But as society became differentiated, and people that had schizophrenia didn't do well economically, right? And they weren't able to provide very well for their children. And because they couldn't provide very well for their children got poor jobs. And then if it's genetic, then there's also, they might have schizophrenia as well. And then they might also not get a very good job. And so they'll hand on this kind of fewer opportunities to their children than were given to them. So even somebody who maybe, kind of think about the patriarch of the family that had schizophrenia, that was very wealthy, but then because of their symptoms, they lost part of the wealth of the family. The next generation maybe had it, maybe didn't. Next generation, maybe you have it again, and again, there's more loss of wealth because of the symptoms cause impairment in occupational functioning. And so now there's another rung down on the SES ladder, and that over time, there's been this downward drift where it's much more likely to see schizophrenia associated with people with low SES because of this kind of social evolution. So which one is right? Are they both right? Well, there's evidence supporting both things, right? We know that male patients diagnosed with schizophrenia are typically less successful than their fathers, right? Which is evidence of which one? Right? The social selection, the kind of the downward drift, right? And that's not true of people without schizophrenia. Well, we'll see about the current generation. But so far in American history, the past 60 years, each successive generation has on average been more successful than the preceding one, where sons have been more successful, have gotten better paying jobs, more educational opportunities, more educational experiences than their fathers before them, right? The whole American dream thing, right? Doesn't hold true for schizophrenia. So that seems to support that downward drift social selection hypothesis. But fathers of individuals diagnosed with schizophrenia, fathers who don't have it themselves, are disproportionately from lower classes. Right? So this father who doesn't have schizophrenia, so he didn't drift down, but people who have schizophrenia, their fathers are disproportionately from lower classes, which is evidence of that social causation, that the father didn't drift down, the kid couldn't have drifted down that quickly, because his father's already lower SES. So maybe there's something to be said for both of these hypotheses. In terms of psychological factors, one thing that we don't believe anymore, and this people believed at one point in time, was about the double bind and the schizophrenic mother, which, like a lot of things early on, they blame mothers for any time anything went wrong with anybody, which probably had to do with some of the other early theorists, Freud, their relationships with their mothers. But the schizophrenic mother was thought to be this kind of cold, unemotional woman who caused pathology in her child, created these double binds where the mother would hold out her arms and say, "Come here, darling," because that's kind of what's socially expected of her. Because she was this kind of cold, heartless person at her core, as the child got close, her face and her nonverbals would kind of indicate disgust or uncomfortable feelings about the child coming close. And so the child is then in this double bind where they're told to come here, but then they're also getting this other non-verbal message saying, "Don't come close to me." And that push-pull experience with the mother causes this split from reality. Right? No support for that. Does not seem to be the case. Mothers of people with schizophrenia don't appear especially cold or emotionally callous, and these double binds don't seem to be associated with schizophrenia per se. So not that, but what does relate to experience of schizophrenia? One thing we know, at least for relapse, is the idea of expressed emotion. Families high in expressed emotion, if somebody suffers from schizophrenia and they have active phase symptoms, usually they go to the hospital, they get on meds, they get stabilized, they get sent home, and they have maybe some residual symptoms, but then they're either going to relapse into active phase or not, or usually it's just a matter of time. People that go home to families that are high in expressed emotion are going to relapse more quickly. They're going to experience active phase symptoms more quickly. And you think, wow, so it's bad to express your emotions? No, it's good to express emotions, but expressed emotion in this context is talking primarily about negative emotions and about being overly involved emotionally. So they go home and there's lots of yelling and shouting, and they're very much involved in the emotional life of this person, because sometimes these people that have experienced these psychotic episodes need some space. And also they have some negative symptoms like avolition, where they don't feel like doing things. They don't feel like cleaning their room, and yelling at them isn't going to make them do it. And so, but you're going to, wow, they're really lazy, and you may yell more and more and more, and that conflict can drive them toward having another episode. So we found that coaching families about expressed emotion can help reduce relapse rates and extend periods of wellness. Related to that, understanding family attitude. So again, educating families about the symptoms seems to be helpful, because in general people are tolerant of the positives. They kind of get, okay, these hallucinations and delusions, that's part of their illness. I get it. I'm not going to yell at them for that. But those negative symptoms people have a harder time with, and they kind of interpret it being laziness. So families that are less understanding, those patients, those individuals are more likely to have worse outcomes. Okay, which brings us to treatment. Obviously, frontline is drugs, antipsychotic medications. A couple of things. Traditional antipsychotics, which we call neuroleptics, work pretty well for about half the people, which not bad. About half the people respond to these, and when we say they work pretty well, mostly we're talking about those positive symptoms. They take away the hallucinations and the delusions. They don't usually have as much of an effect on the negative symptoms, especially if it's somebody who's been suffering from the symptoms of schizophrenia for some time. So usually it's a matter of finding which neuroleptic works for that individual to control their positive symptoms. But then also, you often have to talk about this idea of maintenance medication, right? Where they'll start off with high doses at first, because we want to get rid of those hallucinations and delusions so that you'll take your meds without having to strap you down because you think we're the aliens. But then we want to reduce it, because obviously high levels of any medication, the higher the level of medication, the more the side effects, and some of the side effects are pretty bad. So we want to reduce it down to the lowest level that we can, and we don't have a recurrence of the symptoms, right? Because people without any meds are more likely to relapse. But if we're able to continue meds at a lower dose, we reduce the risk of relapse. We don't eliminate it. Typically, few people can talk about cure for schizophrenia, but we can reduce the rate of relapse if we use these kind of low rates of meds after they've gotten kind of stabilized. Unfortunately, people don't like to take their meds because of the side effects, and also because they think differently, right? The disorganized thinking, and it's not hard to see that if you have kind of persecutory belief system, people trying to get you to take pills, you're probably not going to want to take pills. It'd be a hard time trusting people if a lot of your worldview is built around people are out to get you. In terms of side effects, some motor side effects for some of the drugs, more for the older ones than the new ones, but some of the new ones still have some of these extrapyramidal symptoms, and they're called extrapyramidal because they're mediated by the extrapyramidal neural pathways that connect the brain to the motor neurons in the spinal cord. So things like muscular rigidity, tremors, restless agitation, peculiar involuntary postures, motor inertia, and these things may diminish spontaneously, but they may not. They may be fairly permanent. So when you hear that, okay, muscular rigidity, agitation, involuntary postures, motor inertia, so not moving. Wait a minute, that sounds like some of the symptoms of schizophrenia. Yeah, so sometimes people that are diagnosed with schizophrenia, or they're suspected to have schizophrenia, if they're given these medications, they may develop some of the other symptoms of schizophrenia as side effects for the medications used to treat it, which is cruelly ironic. And then tardive dyskinesia is a syndrome which is becoming more and more rare now because it was a big problem for a while. But syndrome consists of abnormal involuntary movements of the mouth and face, as well as spasmodic movements of the limbs and trunk. Irreversible in some patients even after you stop taking the drugs. So it's when you've caused brain damage from these drugs that have caused these motor symptoms. And fortunately, becoming less common now because people were aware that they were damaging people's brains. Not because they were cruel, but because they were using the only drugs they thought worked at the time, and they didn't know the long-term consequences. But now we do. So the newer antipsychotics, usually referred to as the atypical antipsychotics, introduced in the 90s, they have less motor side effects, some. They're as effective as the old ones, old drugs, at treating the positive symptoms, and they're a little better at treating some of the negative symptoms. But they're not super safe still. So things like clozapine can cause granulocytosis, which is a drop in the white blood cells that can kill you. It only happens in 1% of the people, but if you're that 1%, you probably might be upset about that. So you have to have lab work done regularly to make sure your white blood cells are in good shape and that the drug that they're using to treat you isn't killing you. Some side effects people might still experience: weight gain, obesity with that. But they generally are more tolerable than some of the other ones, and they work a little differently. They usually still target dopamine in some way, maybe at a different receptor site, D2 versus D4. But they also, these atypicals typically also are designed to affect serotonin, norepinephrine, and or acetylcholine. But still, it's a matter of trial and error to figure out which one's going to work for which individual, and maybe not any. In terms of psychosocial treatments, so things that aren't medical in nature, there's not a primary treatment. There's not somebody who has schizophrenia, you don't say, okay, well, they need to see a therapist. First thing usually is, let's find some medications that will help them control their positive symptoms. Because it's hard to do therapy with somebody who's actively hallucinating, right? Who has delusions of being persecuted. You're gonna have a hard time talking with them, unless you're very, very good. But so it's not used as a primary treatment, but usually used as an adjunctive treatment. So you do medication and some other stuff, because we can still help as therapists, people even with more severe pathology. One of the things that there's support for is family-oriented aftercare. So this is about educating families, make them more understanding of symptoms, teach them coping skills, help reduce expressed emotion. And whenever this is done, it delays the relapse. But these programs are often done in a kind of intense fashion. So somebody's about to be released from hospital, so this team of social workers and therapists will go into the home and do all this work, and it's really great, and the person goes home and they're doing really well, but then all that support disappears because, okay, now we got to move on to the next family, and then the family goes back to being the way they were before, and relapse happens. So not real cost effective, but kind of gives the idea that, well, if we could afford to provide this level of care ongoing, probably wouldn't have relapse, or at least reduce the likelihood of relapse. Social skills training. Some of the people with schizophrenia and the different psychotic disorders have social skill deficits that don't get better whenever their positive or negative symptoms improve. So you treat their other symptoms with medication, but they still don't know how to interact with people. And usually, and often, they don't know how to interact with people because they've been kind of odd all their lives. They've kind of thought differently, they've acted differently, so they've been perceived as different, and so they haven't had a chance to have kind of normal social development. So then you can do to improve their quality of life is teach them some social skills, which doesn't necessarily affect relapse rate, but it may make them better socially adjusted, and again, like I said, improve their quality of life, which is important. Cognitive therapy. Some support for this in terms of helping people learn to evaluate, test, and correct distorted thinking. So teaching people to do some reality testing, kind of like there's that scene in A Beautiful Mind with Russell Crowe, where near the end, where he's standing outside and the guy walks up to him to talk about the Nobel Prize, or whatever, and he stops the student and asks her, "Do you see him?" And she says, "Yes, I do." Says, "Okay, thanks. Go ahead." And he was testing reality. Okay, I see this thing, but I want to get corroboration from somebody else. And usually, we don't talk about reality testing involving asking somebody else to help you, but engaging in some process and be able to say, to check, okay, is this real or not? So teaching people skills to be able to do that, and also to correct any kind of distorted thoughts they have, usually about paranoid thoughts. Teaching them to be more empirical thinkers, to look for the evidence that, okay, you kind of suspect this may be true. What's the evidence that's true? How could you check, and how could you be sure? And the effect on relapse, the jury's still out on that one. Another psychosocial approach would be the assertive community training. This is when an interdisciplinary team that does therapy, education, medication, and crisis intervention. And for severe patients, who gets it, it reduces hospitalizations. So people that are basically bouncing back and forth in and out of the hospital finally goes, wow, this is costing us too much money to treat this person, or the insurance company says it's costing us too much money to treat them on this kind of band-aid basis, where they come in, we give them some meds, patch them up, send them back out. Let's fire all our ammo at once and give them this super duper intervention. And when you do that, it works. It doesn't cure them, right? But it reduces the hospitalizations, and you're changing them. You're changing their environment in such a way to make it less likely that they'll experience some of the symptoms, and also less likely that when they do experience the symptoms, that it will cause impairment. So teaching the family and them what to do. Okay, you start to have some symptoms. What do? Well, get back on your meds. Make sure whenever you see that they're becoming more paranoid, don't let them spend as much time alone, right? So you have all these kind of plans in place, and you teach them all these skills, both to reduce the symptoms and to reduce the impact of the symptoms. So again, we're not trying to, we're not going to cure this disorder, but we can improve quality of life and reduce the impact on the person and on the family. And then the other thing that you see mostly in films are institutional programs, for chronic patients. So this is when they have these really carefully structured programs. They might have token economies where you make your bed every day, and you take your meds, and you get rewarded with tokens that you can turn in for cigarettes or whatever. They can result in improvement in terms of what is success for institutionalized programs? One of the success stories that's often touted is once they reported that after 4 years, 11% of the people institutionalized were released. And that is success. So it's all a matter of degree. 11% is better than 0, but 4 years to get just a little over a tenth of the people released, not necessarily symptom-free, but functioning at a level they no longer have to be institutionalized. Okay, so that being said, like I said before, schizophrenia, very diverse group of people that meet criteria for schizophrenia with different levels of impairment. Rare to see somebody like, in A Beautiful Mind, where you have really high-functioning individuals. If they're of above average intelligence, as the character in the movie and the person whom the character is based on, that is a protective factor. And also, if you have lots of family support, that's a protective factor, more likely to be able to function. But for most people, it's a pretty debilitating disorder and causes significant interpersonal and intrapersonal difficulties. And something that we're able to manage, but not known. There's no known cure, and they may be thinking the wrong way, because maybe it's not a disease, maybe it's a neurological difference. These are people that see the world differently, think of the world differently, and if the world can't be different, we have to help them fit into the world, but maybe there's not necessarily something wrong with them, diseased about them, they are just different. I don't know. Okay, that's all for now. Take care.